thank you to Breas for having invited me to speak about our experience on domiciliary non-invasive ventilation. Well, a few years ago, we interviewed most of the physicians dedicated to home mechanical ventilation in Europe. And we find out that in certain European regions, such as Germany, Turkey, Switzerland, and Italy, more than 50% of the patients sent home with a ventilator are COPD. While in other countries, such as Portugal, Greece, Spain, the Netherlands, and Belgium, a small percentage, around 20% of the patients sent home with a ventilator are COPD. So there are quite a huge discrepancy among Europe, and this kind of study has never been performed actually in the US to see what is the percentage of patients sending home with chronic ventilation. We dedicate our effort to ventilate patients with chronic hypercapnia. And my first question to you and to myself is why to target hypercapnic patients? Well, another way to see the problem is the following. Does hypercapnia really determine the long-term outcome of COPD patients? Well, it has been demonstrated that patients with COPD and chronic hypercapnic respiratory failure increase, as illustrated in this study, in almost 50% of the cases by more than 10 millimeters of mercury, the value of PaCO2 during night. And therefore, in my view, if these data are right, and they are surely right because it's our clinical experience, nocturnal hypoventilation is the main determinant for chronic hypercapnia. Well, we still need to understand if hypercapnia per se is a determinant of survival in this patient. In this paper lasting almost 15 years, so a very big, long time frame, the authors compare at time zero a group of patients with similar degree of severity as assessed by the gold stage, and they divide the patient in non-hypercapnic, represented here by this blue line, and patient with hypercapnia. I stress once more the point that these patients were similar concerning the degree of airway obstruction and previous exacerbation. Well, you can clearly see here that patients without hypercapnia have a much higher survival rate at 15 years compared to those with hypercapnia. A number, 38% survival rate in non-hypercapnic patients, 18% survival rate in those patients with hypercapnia. So it's probably true that chronic hypercapnia may determine the survival rate in these patients. And you may say, well, what do you mean for hypercapnia? Which is the level of PaCO2 in which mortality rate is going to increase? Well, in this other study, publishing almost 2,500 patients with COPD, the authors demonstrate that this curve, the mortality curve, is rapidly climbing up when you reach a degree of hypercapnia of around 55 millimeters of mercury of CO2. And is what obviously we also observe in our clinical practice. The patient comes to your outpatient or inpatient clinic, and this PaCO2 is around this target value. Well, the long-term and also sometimes short-term survival is not going to be very optimistic. Back in 2017, finally, the GOLD report introduced as a key point of treatment for this patient the utilization of chronic NIV. And this was a sort of change of paradigm for the GOLD guidelines. Remember, when the GOLD guidelines appeared more than 20 years ago, there was no mention of non-invasive ventilation until this year that I'm showing you now. Among the key points, the panel stated that in patients with severe chronic hypercapnia and history of hospitalization for acute respiratory failure, long-term non-invasive ventilation may decrease mortality and prevent rehospitalization. Interestingly enough, if you watch all these key points, the only treatments that they mentioned that they could improve survival are long-term oxygen therapy. None of the pharmacological treatment suggested in this table is actually able to improve mortality. So I think it's a big step forward on the treatment of this severe COPD patient. In the study that I was mentioning before, we were asking the clinicians, why are you sending home a patient with COPD with a ventilator? Well, obviously, the first three answers were those patients with more than 3 exacerbations in a year, those patients unable to be weaned from the ventilator after an episode of acute hypercapnic respiratory failure, and those patients with a PaCO2 higher or equal to 55 millimeters of mercury. Let's see if applying more or less this criteria, randomized control trials were able to show something convincing. I'm going to show here 3 randomized control trials performed in the last 10 years. There were more studies in the past, but none of them were convincing, partly because of the study design, partly because with time we improve our knowledge, and also the ventilator companies improve the standard of their devices, and also about the improvement in interfaces. Well, this study out of Germany was a randomized control trial in around 200 patients. They were randomized to get standard care, that means oxygen and standard medical treatment, this blue line, or oxygen, standard treatment, and NIV, the red lines. Well, this is a Kaplan Meier curve, and it assesses mortality rate. Well, the results of this study were impressive. When NIV was applied for 1 year, they show a reduction, a dramatic reduction, I would say, in mortality rate from 32% to around 12%. And this is one of the most impressive studies ever published, not only concerning respiratory patient, but all kind of patient. I rarely saw a study so convincing in reducing the mortality of the patient. Together with mortality, the authors also show a reduction in hospital admission in the year of follow-up. Well, it is important to understand what was the study design. First of all, it was performed in stable patients. What do we mean for stable? They included only patients with a stable CO2 level in the previous better 3 months. Last, the ventilator was set to achieve the maximum level of CO2 decrease during NIV. That means they target normalization of CO2 or close to normalization. Later on, 3 years later, out of Holland, the authors designed another interesting study. They enroll patients after an episode of acute hypercapnic respiratory failure required acute NIV. And 48 hours after termination of ventilatory support, they randomized, when still in the hospital, the patient to NIV or to standard treatment, as described for the previous study. The primary endpoint was a composite index including mortality and time to readmission to the hospital for respiratory causes. Secondary endpoints that are interesting to better understand their result were blood gases, lung function, and health-related quality of life. As you can see here, the study was negative, because you see here that the Kaplan Meier curve at 1 year did not show any statistical difference between NIV and standard treatment. Well, is it true that this study is really negative? Or there is an explanation for this? How come the study, the German study and the Dutch study were so largely different? If you take a look of one of the secondary endpoints, that was changes in blood gases, you immediately realize that after 3 months of observation, both groups of patients got a significant improvement in PaCO2. And remember, this study was performed immediately after acute NIV was stopped. So one criticism may be that the patients were randomized due to prolonged hypercapnia after 48 hours after termination of acute IV may represent a sort of mixed cohort with both acute and chronic and only acute hypercapnic respiratory failure. That means that probably they did not wait much time enough to observe, I would say, stabilization of CO2 after an acute episode. But this is still important, this study, because it may say that if you start chronic home NIV in this hypercapnic patient too soon after an acute exacerbation, you may mix up peaches and oranges. To try to, let's say, reconcile the two studies, the German and the Dutch, finally the British are coming. Well, British, as you know, are not considered any longer part of the European community. However, at the time of the publication, the UK were still part of Europe. So we can still consider a European study. The British are pretty smart. And what they found is that they treat patients for an acute exacerbation of COPD with NIV. And they wait at least 2 weeks, between 2 and 4 weeks after the episode, to eventually start the study. That was a randomization between home oxygen therapy and standard treatment, and home oxygen therapy plus home mechanical ventilation and drug treatment. They enroll patients only if they have a pH with a PCO2 higher than 53 millimeter of mercury, hypoxia, and a pH higher than 7.30. So they were more careful compared to the Dutch people. They said, well, we don't want to start NIV right away after an acute exacerbation. We want to wait until the picture is more or less stabilized and the patient can be considered in a phase of equilibrium. Well, these were very impressive results. Once more, I show you a Kaplan Meier plot, and once more, they utilize a similar composite index as the Dutch. That means survival rate and first time to exacerbation. These are the two curves. The blue one represents NIV on chronic base plus oxygen, and the orange one is only oxygen. Well, the time to the first exacerbation or death was 1.4 months in the home alone oxygen group versus 4.3 in the NIV group. Here you can see another way to express their result. They split the two indices. The risk of readmission was reduced from 80% to 63%, and the exacerbation frequency as well from 5.1 to 3.8. So based mainly on these three studies, the two major respiratory societies, the European Respiratory Society and the American Thoracic Society, published with a small interval of time, around 10 months. First came the ERS guidelines about the long-term non-invasive ventilation in chronic obstructive pulmonary disease. Let's see what the ERS have to say. You know, when you write guidelines, you need to assess some question based on the P ecosystem, where P means population, obviously hypercapnia, COPD, I, intervention, NIV, easy, C, control, standard treatment and oxygen, easy, and outcome. So, question 1 was, should long-term NIV be used in stable patients with COPD as compared to not using NIV? Therefore, the German study. We took in consideration the study enrolling only stable patients, not after an acute exacerbation. And this task force suggests that long-term NIV should be used for patients with chronic stable hypercapnia COPD with a conditional recommendation. The second question was, should long-term NIV be used after an episode of acute hypercapnia respiratory failure? Well, we said yes, we suggest the use of long-term NIV in patients with COPD after a light treatment episode of acute hypercapnic respiratory failure, but only if hypercapnia persists following the episode. Once more, conditional recommendation. Let's see the ATS guidelines. Looks different from the European one. The questions are pretty similar. Should long-term NIV versus usual care be used for chronic stable outpatient? They state outpatient, that in Europe is not as the real approach in this patient with hypercapnic COPD. They got similar recommendation. They suggest the use of home mechanical ventilation in this patient. What was the rationale? Well, the panel state that the balance between desirable and undesirable effect of NIV probably favors NIV. The panel was also impressed by the consistency of the direction of effect in favor of secondary outcomes, such as dyspnea and health-related quality of life, only in the NIV group. And these benefits are very likely to outweigh the inconvenience of using a mask overnight. Well, being North America, you are very concerned about cost. Maybe in Europe we are less concerned about cost. And the panel recognized that the implementation of resources and cost of NIV may be significant barriers to the widespread acceptance of NIV in the clinical practice. Question: should long-term NIV be initiated in hospitalized patients with COPD exacerbation? Similar question that we assess in the European guidelines. And the recommendation was exactly the same. But in North America, you were more precise because you said, yes, go for it for an acute episode, after an acute episode of hypercapnic respiratory failure, and you were very specific in defining the time elapsed between the discontinuation of acute NIV and the start of chronic NIV. So the reassessment, the time frame was a good reassessment, is within 2 to 4 weeks after resolution of the acute exacerbation. Question 2, I think, is important. And we forgot totally to assess the question in the European guidelines. Probably because in Europe we have less obesity problem. We are coming close to where you are, but we are not so bad probably as you are now. The question was, should patients with chronic stable hypercapnic COPD undergo assessment for sleep apnea, for example, to rule out overlap syndrome before the initiation of long-term NIV? The recommendation was, yes, we suggest that these patients should undergo screening for obstructive sleep apnea before initiation of long-term NIV. And the following question was, what do we mean for assessment of obstructive sleep apnea? Should it be determined in a laboratory overnight polysomnography? Well, this is really time-consuming and mind-consuming. So based on the clinical practice, I think correctly, the North America said, we suggest not using an in-laboratory overnight polysomnography to titrate NIV and to check the exact amount of obstructive events. So they were very practical, and they suggest to you the stop bank questionnaire that is quite familiar, I think, to all of you, just to rule out eventually the presence of overlap syndrome or eventually hypoventilation syndrome. we state that the German study was designed to target normalization of CO2 level. And this approach was followed everywhere in the world, more or less, in the US and in Europe. But is there any rationale to really target the maximum degree of CO2 before sending home this patient with a machine? The European Task Force suggests that titrating home NIV to normalize or reduce CO2 level may be justified, but with very low certainty of evidence. And the justification was the following. We make a conditional recommendation to the minimal potential arms of target normalization of CO2, and that it is recognized that this is unlikely to be achieved in many patients. While high intensity, that means normalization of CO2, maybe or maybe not have benefits, this is the approach most commonly used in many centers, for sure not in my country. And thus is probably the most acceptable approach for many clinicians, but I would add, but not in all. However, setting NIV to target a significant reduction in PaCO2 requires more time spent in the hospital and therefore possibly increase cost and decrease feasibility of NIV. What have the Americans have to say about this question? Exactly what we suggest. We suggest the use of target normalization of CO2. However, I am like St. Thomas, you know, the guy you want to see if Jesus was already alive. And in our group, we decided to challenge the hypothesis that high-intensity NIV may have some side effect. In this typical patient, you see on the left-hand side the traces of flow, airway pressure, esophageal pressure, and transdiaphragmatic pressure in spontaneous breathing patient in NIV set at the level of 15 centimeter of water of the inspiratory pressure and high intensity set at the level of 32 centimeter of water, so the double of this. And the Germans were right, actually, because they show a dramatic reduction. Actually, in this particular patient, transdiaphragmatic pressure was very close to zero compared to what we observe during spontaneous breathing and also during low intensity. So high intensity is very useful to decrease the vocal breathing. However, look at these trace of pleural pressure on the right-hand side. The patient is using its inspiratory muscle just to trigger the vent. And then the vent reacts as the patient was paralyzed, like pleural pressure became positive instead of being negative. So I don't know if it's good or bad, but I would not really recommend to totally shut off the muscle of this patient. But more interestingly, we observe the cardiovascular parameters, and in particular cardiac output. And we observe that cardiac output on average drops significantly for more than 5 liters to 4 liters, with a decrease of around 28% in percentage from spontaneous breathing to high intensity NIV. And this was not the case in the, I would say, Italian approach of 15 centimeter of water. Well, is it decremental to decrease so much cardiac output? Obviously, in certain patients, no. Decreasing cardiac output may be the scope also of the medical treatment, but I think in the majority of COPD patients, this huge decrease in CO2 can be considered somehow detrimental. Very recently, there was also a Cochrane Library review about the use of chronic non-invasive ventilation in COPD. And they were straightforward in their conclusion. Regardless of the time of initiation, chronic NIV improves daytime hypercapnia. But we saw the beginning may determine the survival rate. In addition, in stable COPD, survival seemed to be improved, and there might be a sort of short-term benefit in health-related quality of life. Indeed, in people with persistent hypercapnia after an exacerbation of COPD requiring acute non-invasive ventilation, chronic NIV might prolong admission-free survival without major benefit on related quality of life. Once more, as usual, they conclude that more research should be focused on identifying participant characteristics that would finally define treatment success. These are the impressive data about PaCO2 changes. These are the changes at enrollment and at 12 months in patients not receiving NIV, and here in the patient receiving NIV. As you can see here, the group of people undergoing NIV show a marked reduction in PaCO2 of around 5 millimeters of mercury, while this was not the case in the group not receiving NIV. Similar results were observed for patients when the 6-minute walking distance were performed. Only patients undergoing NIV on chronic base show significant improvement in the exercise tolerance. One big question that is still left without answer is the following. Is long-term NIV always well tolerated? Well, a long time ago in this paper, we realized that this was only an observational study, that COPD patients with hypercapnia do not have a similar degree of improvement. On the left-hand side, you see the number of patients able to reduce by at least 5 millimeters of mercury the value of CO2 after 4 weeks of NIV. But on the right-hand side, you see those patients who were not able to reduce significantly the reduce of PaCO2, and actually one patient increased the level of PaCO2. And if you go and look it into details, the study, the most important randomized control trial, you see that the rate of dropout or non-compliant patient, that means that they could not ventilate at least 5 hours a night, was pretty huge, from 11% of a British study to 48% to an Australian study. And so I can conclude that around 30%, 3 out of 10 patients, are not really compliant to NIV for several reasons that we may discuss. The last point that I want to discuss with you, question only rose by the ERS panel, was the following. When using home NIV in COPD patient, should we use fixed pressure modes or adaptive or auto-titrating pressure mode that at least in Europe are very popular? Well, we suggest to use fixed pressure support mode as first choice. What was the justification? While there may be benefits based upon the included short-term study, further research is needed to demonstrate safety, especially when servo control mode are used, and therefore you rely to a variables that is able to determine other variables. These modes are also called hybrid modes for NIV. There are at least two different, if not more, hybrid modes on the market. Volume target modes, that they may target a preset tidal volume, such as the AVAPs or other preset alveolar ventilation devices. In either case, the target is achieved by monitor estimation of respiratory volume using in a built pneumotap and automatically adjusting pressure support with preset minimum and maximum values to achieve what we decide to be tidal volume of ventilation mode. Well, we face probably problem with this mode. And hybrid mode refer to what we call fuzzy logic and fixed mode, the classical logic. Fuzzy logic was, to my knowledge, firstly applied in washing machine based on the weight of clothes that you put inside the washing machine. They regulate the amount of water need to wash your clothes. The fudgy logic is exactly the opposite of the classical logic. Classical logic only permits conclusions that are either true or false. In this aspect, this is green and this is red. However, there are also propositions with variable answers, such as one might find when asking a group of people to identify a color here. What is the real green here? And what is the real red one? Is this real red or is it already pink? Is this still green or maybe a little bit of pale blue? Well, the fuzzy logic and therefore the hybrid mode are interesting assumptions for the ventilatory mode. But do they work in real life? Well, this is a recent systematic review of the physiological studies performed using the targeting tidal volume mode. These are the main outcomes. And you see here, we did not observe any major changes. Some changes on the main outcome were similar. In other study, tidal volume was lower, in other higher, and also the secondary outcome were basically all similar. And you need also to consider one thing. Brigitte Farou out of France, in a study published on intensive care medicine, entitled the paper with a provocative question: are home ventilators able to guarantee a minimal tidal volume? Because remember, most of the cases, tidal volume is an estimation, it's not a real measurement. And she concludes that the performance of the ventilators with regard to their ability to respond to a pathological situation in this resolution varied widely, and no ventilator was able to adequately deliver a minimal tidal volume without an overshoot and or huge dysynchrony between the patient and the ventilator. The other way to see an hybrid mode for home mechanical ventilation is, and is very popular, is targeting alveolar ventilation. For example, intelligent IVAPs combine pressure support ventilation with a target volume aimed to guarantee a set alveolar ventilation by adjusting the level of pressure support within a predefined pressure ranges. Well, the target alveolar ventilation calculation is an estimate of the average tidal volume as a function of the body weight and the anatomical dead space. Well, we know from the physiology that physiologic or total dead space is equal to the anatomic plus alveolar dead space, which obviously you know is the volume of air in the respiratory zone that does not take part in gas exchange. In health adult, all of us know that the alveolar dead space can be considered negligible. However, one can see an increase in lung disease, especially those with increased resistance, where the diffusion membrane of the alveoli does not function properly, or when there are, as in COPD, ventilation perfusion mismatch defects. So once more, you need to take this mode very carefully. And once more, I show you the result of the 6th study comparing traditional pressure support setting with target alveolar ventilation. Main outcomes, all similar. Other outcomes, all similar. No benefit, as a matter of fact, of using this hybrid mode. In the last few years, it became extremely popular because of a very aggressive advertise. The way to set the expiratory pressure with force oscillation technique, and therefore to avoid flow limitation. The ABAPS AE modes combines the target volume to an automatic adjustment of the expiratory pressure level. Obstructive apnoic events are detected using what we call FOT, or force oscillation technique, that dynamically determine upper airway resistance. If apnoic events are detected, the expiratory pressure is increased to obtain upper air patency. Well, we have only 3 studies in the literature. 2 of them lasting 1 night and other lasting 1 week. So we can't conclude anything, but I want to remind you how the concept of flow limitation is very complex, as you know from the physiology. It changes between end inspiration and early expiration. It changes accordingly to the zone of lung where you're dealing with. And it changes greatly with position. So I still need to be convinced that this mode of ventilation is really working. Well, I will end my presentation with a song by Iggy Pop. And the song is called Life Behind the Mask. And I like this sentence. You are wearing a mask and you look better that way. But I cannot finish without sharing with you my happiness, because finally my football team won the second league championship and we are back in Serie A, that means first league, after 26 long years. And finally, after we were relegated in 4th division 10 years ago, we came back and we are going to give hard time to all these big teams like Juventus, AC Milan, and so forth next year, I'm pretty sure. And I thank you once more for your attention.
Thank you very much, Professor Nava, for a very entertaining presentation, and congratulations with the presentation, but probably even more with your football team, your soccer team that made it to the 1st division, because we know that soccer, that is ruling your life with you guys in Italy.